So I got this. Thank you very much, Zoe. I worked for the past, among other things, for the past 7 years with startups. So I've worked with a lot of tech bros trying to start mental health companies. And all of them are, it's a guy who's like, this is what worked for me. It will work for everyone. And it never does. So thank you very much, everyone. It's a real honor to be here. I'm going to talk about the work we do at Clerkenwell Health, running clinical trials. What have clinical trials taught us about mitigating risks in psychedelic-assisted therapy? You'll hear a lot of talk about psychedelics being very safe, and much safer than other drugs, much safer than alcohol, and so on. And the comparison, I think, is the wrong one, because we're using psychedelics to treat people with mental health problems. So we're using a compound that's very, very destabilizing to treat people with often very unstable mental states. So I think the comparison is a bit off. And actually, we do see some very, very unusual, very distressing, sometimes horrifying to the individual risks, side effects, harms, distress, those types of things. And it's really important to be aware of them and to know how to spot them, prevent them, manage them, and so on. The risks tend, I think, to be under-discussed and under-emphasized, although that's much less the case now. When we started our training program, which I'll plug, we actually got quite a bit of pushback occasionally from industry insiders who didn't really want us talking about risks and harms and abuses and things like that. But we think, I'm a doctor, so I think it's really important to balance risks and harms, and also to not be afraid of risk. Surgeons open people up with knives, and that we understand that you have to do some harm sometimes to do good. And as long as people are adequately consented and informed and cared for, I think that is acceptable. So, what are we going to talk about? So we're going to talk a little bit about what the range of risks is. I'm going to talk about the types of things we've encountered in particular and that I think are particularly interesting for this audience and for the work that we do and how we manage the risks. And build an argument for the approach that we take at Clerkenwell, which is an approach that's certainly based on the evidence. There isn't that much evidence, actually, for the types of things we'll talk about. So we rely a lot on first principles, very much a first principles approach. And I'll tell you a bit about what I mean by that. So what are the types of risks that we see? Well, there's some physical risks. They tend to be pretty minor, not very complicated, mainly sympathomimetic, so increased heart rate, increased blood pressure, and so on, some medication interactions. There are risks of therapy itself that are amplified by psychedelics. There are risks from practitioners that are, again, amplified by psychedelics. A couple of things that I won't go into detail today, but clinical trial-specific risks. Antidepressant withdrawal, so on almost all the studies that we have run to date, people have had to come off their antidepressants over a 6-week period, which is enough for some people, but when you've been on antidepressants for 10 years, it's a very short period of time. And there's much more and better research now about how difficult and sometimes harmful taking people off antidepressants too quickly can be. So that's an issue, though we're increasingly seeing studies come through now where people are staying on their antidepressants. There is this hypothetical risk of serotonergic interactions between antidepressants and classical psychedelics, but not much evidence that that's actually dangerous. And then disappointment, because in the first phase of our trials, there's a placebo arm, generally speaking, in our phase 2 and 3 studies. And no matter how much we prepare people and talk to them about it beforehand, it can be devastating to go into the room after 2 months of preparation and to take a medication and then nothing to happen. It can be absolutely devastating. And we have had people just storm out. We've had people get very, very angry, very, very distressed. So it's an important thing to keep in mind. It's something that we talk about a lot when we prepare people. There are short-term psychological difficulties that people have. Challenging experiences is the one we'll talk about today. And some medium-term risks, increased suicidality. So see like 7 to 10% of people in Compass phase 2 studies and in the MAP studies had increased suicidality, so something to keep a close eye on. A context mismatch, so sort of a which I'll go into in more detail, but is something that is not considered and is quite specific to psychedelic research. Metaphysical or ontological shifts, theoretical risk of psychosis, and then longer-term risks like reactivation, HPPD, which is hallucinogen persisting perceptual disorder, and post-traumatic stress disorder. Interestingly, on some of our psychedelic PTSD studies, we have people who have PTSD from doing psychedelics themselves at home. They want to come back in and do it again in a different setting to treat it. So these are the things we'll focus on. So this is my book that's coming out in May about psychedelic research. At the end of the book, you take a quiz to decide which one you are. So this is a joke. I haven't really written a book. And I don't really think that everybody in psychedelia is one of these three. I'm sure nobody in this room is. Well, it's probably 10%. But there is something about the field that does attract bad actors. And I think there are two types of risks when we think about the risks of therapy and the risks of therapists. One is the amplified risks of therapy itself. So therapy has side effects. We tend not to think about that. And then there are also risks from bad actors. A hill that I will die on is that the biggest thing that we could do for mental health treatment generally is to very, very, very carefully select the people who treat mental health problems. So I think that this is a famous study called Waiting for Super Shrink by Okiishi et al. And these are the best therapists and the worst therapists in their study. It's a large study of therapists. And you can see that there were some therapists who were extraordinary. So the scores dropped precipitously over the course of the study. And some therapists where people didn't get better or got worse. So there's a small group of people with a certain set of characteristics who are really, really, really effective practitioners. And I think what we should do is should be finding those people. I think that's much more important than qualifications or, how many letters you have after your name. So that's the hill I'll die on. That's my first controversial statement of the day. I was gonna arrange my talk as a set of controversial statements based on the talks of the other people on the panel, but I decided that was me. I didn't know them well enough, I think, to do that. So we spend an awful lot of time and effort selecting therapists. So just to give you an example of what that looks like, we recently advertised for 2 posts. We had 200 applicants, and we offered a role to 1 person. So we put them through, many, many stages of observing them in clinical skills, interviewing them, and so on. And what we're looking for is people who are curious, thoughtful, flexible, appropriately self-critical, so people who can reflect on their work, people who are able to reflect and learn, and high in a set of skills called facilitative interpersonal skills. If anybody, I'll share the presentation afterwards for the references, but FIS is a framework for assessing the people's kind of innate ability to engage and interact and convince and so on. So I think that a lot of the issues that we try to prevent, which are due to the kind of amplified risks of psychotherapy, are we attempt to mitigate through really carefully selecting therapists. I'm encouraged to see at least 4 of our therapists in the room today, so that's good. All of whom went through that process. But also important to think about the broader team. So set and setting is a term I tend not to use anymore because I think it's one of those kind of stock phrases that people kind of don't really think about when they use it. But what it means is, obviously the person's mindset, but the setting is not just the room, which I think people tend to think, the room should be nice. That's important. I worked in the NHS for 22 years, so I know what it's like to try to treat people with enduring distress in really ugly environment. But it also means that who picks up the phone when the person calls us. How careful are we about not like rescheduling and putting them out, and how do the person who greets them at the door, all of that is setting. And so we're also very aware of the broader team, the dynamics within the broader team, and the training of the team. And my colleague Ashley is here as well, is always pressing me on that, making sure that the team's talking to each other, understanding the dynamics that are going on in this very amplified environment, crucially important. I mentioned context mismatch at the beginning. We had a participant early on in the history of Clerkenwell who was a woman with PTSD who had just an absolutely extraordinary improvement after one treatment of methadone for PTSD. So very like MDMA, methadone, not methadone. People often mishear me when I say that. Incredible, like it went from the highest, almost the highest score you can get on the CAPS-5 PTSD scale to 0 after a single session. Miraculous. I'd never seen anything like it. We do occasionally see that kind of just sort of almost cure, although it's not a word we should use in mental health. And she went back home, and her partner found it impossible to deal with the fact that she was no longer this fragile, person who depended on him, and he became extremely violent, assaulted her the next day, and she ended up in the emergency department. So Betty Eisner famously expanded the idea of setting to social matrix. So we have to think very, very carefully in preparation, because the person is going to go through this absolutely extraordinary experience, and then going to go back to their broader context, and the broader context may completely mismatch them and what it was before. So we've had Sikh and Muslim patients who have come in and are very concerned about what's going to happen when they go to their home environment. A group, are they going to be shunned, judged, and so on? And then when people change, they go back into an environment that hasn't changed, and that's something we really need to think about carefully. So that's all in preparation. We missed that. We missed that with that patient. I confess we did not explore enough what the nature of her relationship was, and how safe she was and how safe she felt. It's 2 years later. She's actually doing really well. We've been through a whole process with the police with her, and she gave me permission to talk about her experience. But she's doing well now. So context mismatch and the risks of improvement are important things to think about that you don't normally think about. And it's partly because of the dramatic nature of the improvement, partly because of the dramatic nature of the experience itself, and partly because of the attitudes of people who haven't gone through the experience, what they might think. So it's very important. One of the other things that's really important when we're running clinical trials, but also when delivering any kind of treatment, is to ensure that we're not imposing any kind of ideology on people. Because, this room is very nice, and it's very pleasant, and it's better than the NHS in many ways, but it's impossible not to miss that there is a subtle implication of that there's a way of thinking that is preferable, or a kind of a cultural affiliation. So the types of people that we want to work with are the types of people who are careful about not imposing any kind of personal or their own cultural ideology on other people. Because ontological shifts is one of the risks of psychedelic treatments. Not something we've seen very much of actually in our clinical trials, but something that we're definitely very aware of. And something also ties into, then going back into a mismatched context. Jules Evans and colleagues have produced some really nice research around this, things that people found helpful after big ontological shifts, things like social normalization, grounding, embodied grounding particularly, and reframing the experience as an inner mind state rather than a cosmic fact. So there are some things that people themselves have found helpful. You ran this paper as well, actually, weren't you? Yeah. So there is evidence there, and so one of our principles obviously is continuing education, staying up to date with the research, learning from each other. But there are often places where the evidence lets us down, and in that case we're relying on first principles. And if anybody doesn't know what I mean when I say that, what I'm talking about really is that there are things that we know or we're pretty confident about how the mind works, how people work, how the mind works, how mental health problems develop, how they get better, that we rely on when when we enter a situation where there isn't good evidence for like, this is the treatment for this. And actually in most cases, mental health, that's not really how it works anyway. If you read the nice guidelines or other kind of algorithmic treatment protocols, you wouldn't get that impression, but it's actually not really the case. When I taught in Oxford for many years, I used to tell the medical students that if they wanted to pass their psychiatry exam, they just keep saying CBT and antidepressants over and over again, and that they'd pass, because that's what all of the treatment guidelines look like. We rely a lot on first principles. I'll go into that a little bit more detail when we talk about reactivations and HPPD. It's also really important to have, so we're really careful to find great therapists, but they're not always very experienced therapists. They're people that we feel have an innate skill and ability to connect, empathize, make people feel welcome, cared for. But you also need deep experience of complexity in order to have a stock of these first principles, ways of understanding people, and a suite of different ways of thinking, different schools of psychotherapy to draw on. Doesn't have to, those are often psychotherapists. Sometimes having a medical point of view is helpful in those as well. I worked with people with chronic physical health problems for many years. It's helpful to understand physical symptoms and psychological symptoms as well. And then learning together so that those great therapists can then become the people with deep experience of people with very complex problems. The clinical trial adverse event reporting has not really caught up with the complexities of psychedelic, the types of experiences people have on psychedelics. I really, really encourage people to have a look at this paper, which presents a really nice framework for understanding the different types of experiences people can have. This is a list of the areas, so perceptual difficulties, we'll talk about in a second, affective, cognitive, metacognitive. We've talked about psychotherapy-related risks, behavioral problems that people have afterwards, sleep problems, compulsive behavior, behavioral, interpersonal, psychospiritual, and sociocultural. Really nice framework for thinking about the different types of things, because often if you don't ask people about these things, they won't tell you about them. So these types of things get missed, because when we ask about symptoms, people think we mean like, nausea and vomiting, and, panic attacks and things like that. So important to keep these kinds of things in mind. Challenging experiences. So these are inevitable, pretty much, particularly in the types of patients that we see. I do think critically important, for when people do go through them. I think often really useful material for insight and recovery, but it can be very difficult. And so you do need those really skilled practitioners who are able to sit in a room with the person having a really difficult experience. That's one thing, is the acute experience itself. And I think it's actually not that different from the skills a therapist has in dealing with a person with any kind of severe distress, very angry patients, very distressed patients, very upset patients. So I think those principles carry over. I think it's much more important that we select really great therapists than it is that those people have psychedelic experience, for instance. I'm not a psychedelic exceptionalist. I think that can be useful for sure, but actually those skills are transferable. And I think there are many reasons, many mechanisms, psychological, relational, social mechanisms through which psychedelics affect their action. I'm very fond of Max Wolf's idea that, which Ali Beiner spoke about just a minute ago over in the other lecture theatre, which is that in normal day-to-day life, avoiding difficult things makes you feel better. But during a psychedelic experience, trying to avoid difficult things makes them much, much worse. And so through that, you're sort of training people to go through difficult experiences. Sort of like one of those bicycles that's set up, the handlebars are set up backwards, so if you turn left, it goes right. And you have to train yourself to do it the other way. I think there are other mechanisms, and we have actually, interestingly, had some people who have not been able to do that and really felt like they failed. But a skilled therapist was able to support them to reframe and rescript what had happened, actually. And one memorable case, a participant came in And she'd been up all night before her 5-MeO dosing, reading Erowid accounts. And she said, I'm really worried I'm going to go to hell. I thought to myself, I'm pretty sure because you're worried about that, that's going to happen now. But she had, and it did, and she had an awful time. And she wasn't able, it was so intense, she wasn't able to, lean in and go through. But afterwards, she was a person who had terrible abuse and neglect from medical services over the years. During the experience, she was able to ask for help. And the whole experience of going through the study required her to put her trust in us and me as a male doctor. So I represented, a lot of the, I looked and sounded like a lot of the people who had done her harm in the past. But she did it, and she was able to go through it. And so she was able to re-script that experience as she was able to, she was able to trust these people, and she did it despite how afraid she was, and so on. But it took a really skilled therapist to be able to do that with her. So that is fundamentally important for that type of person who has that type of experience. I'm very excited to hear about hormesis as another potential mechanism that Ida is going to talk about afterwards. So we do a lot of work in the preparation and assessment, looking for the types of people who are more likely to have challenging experiences. We'll find those challenging experiences more difficult when they have them. And so that's critically important. And then, of course, throughout the whole process, if you have a team that you really trust and that you can tell that you're having difficulty and you can talk about them afterwards, then that's crucially important as well. So again, thinking about the person's support network and also thinking about the whole team of people that they interact with is critically important. We see reactivations very commonly as well, particularly with our 5-MeO DMT studies, particularly in women, particularly in the hypnagogic and hypnopompic states. So I think the literature suggests that about a quarter of people on 5-MeO studies have reactivations. We see that, or maybe even more. And they can be very, very distressing and unpleasant if you don't know what they are, and if if you're not warned and educated about them beforehand. So understanding that literature and who's at risk is really important to prepare people. So that evidence, again, the evidence base is really important, and then the skill in supporting people to navigate through that is really important. We know from the literature about 10% of people in naturalistic psychedelic use report some kind of functional impairment in days or weeks after use of a psychedelic, and about 3% of those require psychiatric treatment. So we can use some of those data to kind of inform people what the likelihood is and so on. We know from Robinson et al., another research group Jules Evans was part of, that there are things that people find really helpful when they have persisting problems after psychedelic use, support from peers or professionals, cognitive, like meditation or embodied exercise, self-care, meaning making from the experiences they're having, and some people find pharmacological interventions helpful as well. This is a good example of an area where the first principles are really important. So for challenging experiences or reactivations or any aspect of the psychedelic experience to become a persistent problem, so HPPD, we haven't actually seen that. I think it's because we are able to speak to people about their difficult experiences, educate them about them, and use what we know from other types of symptoms, teach people how to navigate them. So any symptom, this is a kind of first principle, any symptom can become persistent if you pay a lot of attention to it, if you're very afraid of it, very distressed by it, and if you change your behavior because of it. So that could be chronic pain, tinnitus, anxiety, depression, abnormal perceptual experiences. HPPD, for people who don't know, is any kind of persisting perceptual abnormality, can be continuous or intermittent after the use of after psychedelics. So sometimes things like visual snow or moving patterns. And people can find it really unpleasant. But if you prepare people for it, well, it seems to be the case in our experience that if you prepare people for it, pay attention to reactivations or other types of experience after their dosing, and teach them how to navigate it, that works really well, and we haven't had any persistent problems like that. But again, I think it's that deep experience of other types of symptoms and other types of health problems generally that has helped us do that. So that's the list. So lots of focus on preparation and assessment. So SAT, lots of focus on not just the setting, not just what the room looks like, but the broader team and the social context the person's going back to. Attending to first principles where there is no evidence, finding and training great therapists, having people with deep experience of complexity on the team who can then train those excellent therapists to become the people with deep experience of complexity, learning together from each other and from the evidence-based continuing education, staying up to date with the literature. Not rocket science, but that's how we do it. And to sort of say it differently, so carefully chosen practitioners who are and feel well supported by colleagues with deep experience of complexity and who are abreast of the evidence, but use first principles where evidence is lacking or poor. So sometimes it's not just that there isn't evidence, it's that there's loads of evidence and it's very poor quality, and who attend closely to the broader network of influences on health